just just to make sure. All right. So, hi, my name is Simone. My pronouns are she, her. I am the education program coordinator on behalf of Safely Connected, which means that I deal with primarily manual research, manual editing, and manual creation, but I'm also responsible for workshops such as this one right here. So what Safely Connected does is try and create, or at least my part with Safely Connected, is try and create manuals that can be used as guides for future trainings and workshops around specific topics and how they intersect with eating disorders. My work has been primarily with the general healthcare practitioner manual that I've been creating. And this includes community interviews, researching, writing, editing, what we currently already have in our manual, and just generally trying to create a manual that can be used in future guides with general healthcare practitioners. As well, I'm currently in my third year of recovery from anorexia nervosa, and I also have an anxiety disorder and depression. I have a bunch of health issues, including chronic pain, fatigue, and joint pains, but no formal diagnosis that I can use to kind of define these issues. I have a difficult relationship with my body because of the development of an eating disorder during puberty, and a lot of continued unanswered questions about my health and well-being. Similarly, my relationship with medical care is very uneasy because I'm continuing to pursue diagnoses and seek treatment for my medical problems, but without very much luck or aid from professionals so far. Identifying as a person with a disability is still something that I'm really getting used to, and I want to be transparent about that. It's not an easy topic for me to discuss. And this is really in part due to a lack of validation that I get from a lot of healthcare professionals and a lack of labels or diagnoses that I can kind of use as a basis for whatever my condition is. Still, I identify as a person with a disability because I'm deeply affected every day by my symptoms, and they're a massive barrier for me to overcome. And I don't want to minimize the effects that they have on me in my day-to-day life. I also know that I'm not alone in these struggles. I've interviewed a lot of people on behalf of Safely Connected about managing eating disorders as a person with a disability or chronic condition. And it's really evident how hard it is to navigate these intersections with other parts of your identity in regards to eating disorders and eating disorder recovery. It's partly why I chose this topic for the workshop, since it's something that deeply affects me and also the people I care about. I'm surrounded by amazing people from many different backgrounds, including people with disabilities similar or different to mine. And, we see a lot of this in a lot of different ways intersecting. Outside of my work for Safely Connected and my personal experience, I've also written articles and poetry about my experiences with medical care and eating disorders. I have researched and studied disability effects on language, and I've been a vocal advocate for accessible ED care and a strong opponent to diet culture to pretty much anyone who will listen to me. Another big part that I want to kind of preface the entire workshop with is my privilege and something that I want to acknowledge. I'm a cisgender white woman without a visible disability, and my experiences and perspectives are always going to be affected by those labels and that identity and the privilege that it creates for me. My goal is always to expand my understanding of social issues as much as possible, even if I may never experience them, and that really navigates a lot of my work on behalf of Safely Connected. So that being said, I really want to thank the entire team at Safely Connected, including Cody for being a mentor and Taylor for being such a great support system and number two on this workshop, as well as individuals within the community who agreed to be interviewed, for dedicating their time and energy towards this presentation and all of my other work on disability and eating disorders at Safely Connected. So before we begin, we have a little quick introduction question that we want to do to kind of gauge how people, what people already know about this issue. And that question is, have you ever had a negative experience with a medical professional because of something that you can't change about yourself or some sort of label? And Taylor has put a message in the chat with the app where we can see, where you can send in your answers. And then if you want, you can submit that and we can observe the answers anonymously, of course, to this question. And I'll give you a couple minutes to digest it just so that you have time to think about it and also time to access the app, or if there's any issues with that, please let us know. Also, Taylor, your screen changes with when you click out of it.
Can you see that one?
We can see the Slido, not the slides.
Perfect.
So far, 100% yes. Okay, so we're going to check back in with that in a second. I just want to give you guys a second to process it, and then also you can continue thinking on it if you feel comfortable doing that while we're talking about some of the topics that we're going to be covering and some preliminary definitions. And we will circle back to that in just a second. It's just important to give you guys the time to actually process this. So the next thing we want to talk about is some definitions that come with disability and come with chronic conditions, just so that we're kind of all in the same space about what exactly we're talking about when we talk about these issues. Other definitions are going to follow as we cover topics. What's important to remember is that language is a tool that we can use when deconstructing common biases and narratives around disability, marginalization, and eating disorders. And appropriate language usage allows us to affirm and validate the experiences of others. But still, at that same time, as we're talking about the vitality of language, we also want to stress that these descriptions we're giving are not all-encompassing to the meanings of these words in their realization. Really strict definitions of what something is or isn't can be demeaning and damaging to a person. We never want to devalue anyone's experiences based on if they fit into these narrow criteria, because this can really create a strong risk for traumatization or re-traumatization. So the first definition we give is chronic pain, which refers to pain that carries on, constant or fluctuating, for longer than 12 weeks, despite medication or treatment, which would typically alleviate symptoms. Next is chronic condition, also called chronic illnesses by some individual, but we are going to be talking about that distinction in a second. These are conditions that last at least a year that require ongoing medical attention or limit activities of daily living, or both of those together. And then the third one we're going to be covering is disability, which generally describes functional limitations that affect one or more major life activities such as walking, lifting, learning, and breathing. For this workshop specifically, we're going to be focusing on mobility issues, chronic pain, and diet-affected conditions. But there's obviously other intersections within disability that we just don't have the time or resources to focus about within this workshop. So we really encourage you to continue looking into how those may intersect with disability and how those may intersect with eating disorders. One very strong one is neurodivergency, which Safely Connected will be doing another workshop on. So make sure to keep an eye out for that one. And to kind of understand these definitions in a more personal way, I'm going to probably be using myself as an example a lot, just because it helps to have these sort of things personalized. So for example, chronic pain is something that I struggle with because I'm in pain, and I have been in pain pretty significantly in some sort of capacity since I was 15 years old. It is likely caused by a chronic condition, although we don't know which one. Since I don't know what the condition is, or I can't provide myself with any sort of diagnosis or affirmation about what exactly it is, I feel comfortable using the term chronic illness for myself. But again, that's very much dependent on the individual, and not something that I feel comfortable with, but that doesn't mean that other people are obligated to or even should feel any way about it. As well, because I have limitations that affect my ability to walk, lift, run. Sometimes I have cognitive delays in the way that I'm able to think or articulate things. This considers it a disability. So next, we want to talk about language. Language is a very important tool, like I said before, but we want to make sure that it's a tool that we're using appropriately. So first, we're going to cover what both types of language around disability are, as well as some common do's and don'ts. But what we really want to emphasize, and what I will probably say 100 times throughout this whole workshop, is that we want to respect the individual's autonomy and their choices. And a big part of that is respecting the way that individuals identify themselves and identify their circumstances and experiences. Typically, the practice we use is called asking and mirroring, which is you check in with what sort of language a person feels most comfortable with, and you also mirror the language that they themselves use. So this can look like asking questions such as, what labels do you feel best describe your experiences in the past? Or it can be more formal or less formal than that. It can also look like listening to someone's story about their disability or their experiences as a person with a disability, and then using those same kind of ideas when you're repeating or discussing the topic further with them. So the two types of languages that is typically used for people with disabilities is person-first language and identity-first language. Person-first language recognizes them as a person first and foremost, which emphasizes their right to fair treatment and respect no matter their disability. So this can look like centering a person rather than centering their disability as an equal proponent to their personhood. This is a strong tactic because it separates from a long history of dehumanization and mistreatment, including the use of inappropriate names, medical mistreatment, and stigmatization. It also allows people more flexibility in what sort of language they identify with, since their disability or diagnosis is established secondary to themselves. So this can kind of look like terminology such as person with a disability, person requiring a mobility aid, or person with a physical injury. Generally, this is the preferred terminology to use unless you're aware of what the person's comfort is with certain terminology. But we can kind of get into that distinction as well in just a second after I define identity first. So identity first centers the diagnosis as a part of someone's identity equal to other descriptors. It kind of makes the person and their disability one and the same, not in a way that it overtakes their personhood, but rather that it's acknowledged as a necessary part of understanding someone and where they come from in their experiences. This really comes from the idea that disability is important and can be inseparable from the self. And this also helps encourage dismissal or ignorance that comes with seeing it as secondary to someone's personhood. As well, it can also be an important strategy for reclaiming disability language or as a means of establishing community. And this sort of language can look like saying disabled person or a blind person. Most groups are more commonly some groups are more commonly associated with identity first language, while others feel the two can be used interchangeably. But both of those are very specific to certain forms of disability or certain communities that are found within people with disabilities. So for example, people that are blind or deaf are more likely to be comfortable with identity first language, and people with autism are more likely to see that variability between each individual on what language they feel best reflects them. Like I said, the most appropriate terminology is dependent on each person, but really, again, we want to emphasize the fact that make sure that you are using the language that is most appropriate for the circumstances. And if you don't know for sure, use person first languages. Okay, perfect. So then we're going to hop into some common do's and don'ts that we see around disability language. So first, the do's. Make sure that you understand the difference between person first and identity first language. If you are confused, if you would like more examples, if you want me to elaborate in any way, please let me know. Send a message to Taylor, send a message in the app, anything like that. I'm more than happy to continue talking on that if that's something you need. But really understanding the difference can go a long way in making sure that someone feels validated and understood in their experiences. Next, like I said, asking and mirroring is very important when you're discussing disability. Use terminology and ask questions like, what sort of language do you think best reflects your experiences? What makes you feel most comfortable when we're discussing this, et cetera, et cetera. Make sure that you're being sensitive when you're using words like illness or disorder, and you want to substitute them with condition when possible. Like I said, for me personally, I feel comfortable with referring to myself as someone who's chronically ill, but that's very much because of the ways that my symptoms have manifested over the years and my treatment from medical professionals in regards to labels. Most of the time, these words really have either a negative connotation for the individual or they can feel very stigmatizing. So we want to substitute them for a more neutral word like condition. Another important one is always acting respectfully without infantilizing or patronizing anyone. And finally, being honest about your educational background around disability to leave room for improvement and correction, either from the individual or from more wider sources about disability or about these kind of topics. So for me, myself, although I do identify as someone with a disability, my journey to that point is very new to me. And so I like to make sure that I inform people of that when I discuss these topics, because I want to make sure that I'm approaching this as understanding as possible to how my experiences may not be the same as other people's experiences. As for the don'ts, don't use pictorial metaphors or negativistic terms that imply any sort of insufficiency, as well as excessive or negative labels. And this can look like referring to someone as a victim of something, or adding words in front or after discussing the disability, like kind of or very, things like that. You never want to refer to someone as kind of having a disability or having a very big disability, because it either delegitimizes their struggles or their experiences, or it forces them to feel like they have to justify their position and how they identify themselves. As well, we don't want to use any sort of terms that can be regarded as offensive, including slurs. We also don't want to assume that language that one person is comfortable with will work for others who share that same condition. And this can be a bit of a struggle, especially in communities where you see person first and identity first kind of happening interchangeably depending on the person. You never want to assume that the language that you're using will also be what someone else with a disability, whether it's the same disability or a different one, will also feel comfortable with in those same circumstances. As well, we want to avoid using any sort of euphemisms that can be condescending, such as special needs, physically challenged, or referring to someone as handy capable. And finally, we want to make sure that we're not approaching topics involving disability as taboo or inappropriate. We really want to normalize these sort of conversations and be honest about our feelings in regards to them, but we also don't want to shy away from them just because there's a sort of social stigmatization that's being perpetuated by keeping silent about these very important topics. So before we hop into any of the actual workshop material, we're going to circle back and talk about that question that we had a couple of minutes ago and look at the answers to see what people have said about their experiences. So so 100% of people said that they've had a negative experience with a medical professional because of something that they can't change about themselves. And I'm not surprised by this. It's a really shared complaint and a shared concern between individuals that even if someone is a medical professional and is working their best to establish a safe space, simply a lack of education or a misunderstanding of symptoms or identities or labels can really cause a miscommunication that creates negative experiences and can even manifest into trauma. I know for myself, I've had a lot of negative experiences with medical professionals, and I would probably hit the yes button like as hard as I could. And we really want to try and minimize the amount of people or the impact that these sort of experiences are having on people, because medical professionals are supposed to be people that you can look to for aid and support and care. So that's one of the things that we really want to use as motivation as to why these kind of workshops are important. It's to make sure that we can kind of turn some of those yeses into nos one day in the future. Okay, so now we're going to talk about what eating disorders are. So eating disorders refer to a mental illness that affects one's relationship with food, including irregular eating habits and severe preoccupation with shape, weight, or eating habits. So what we really want to stress is that anyone can develop an eating disorder at any time, no matter what. This includes age, gender, sexuality, race, religious upbringing, geographical location, and many, many other factors. All of these different labels and identities that people have does not impact their ability to have an eating disorder. And this is really important because there's a lot of preconceived notions about what exactly a eating disorder will look like when it manifests within people. And because of this, a lot of tools for diagnosis and later treatment plans are catered to a very strict subset of individuals with eating disorders. And those are young, thin, white, cisgender, middle-class women without any sort of disability. There's also a lot of commonality, but a lot of uniqueness in eating disorders. So we want to stress that it's not an experience that one person is experiencing and no one else has ever even come close to understanding it. but it's also important to recognize that one person's manifestations are not going to look the same as another person's. That's another reason why we don't want to discuss symptoms here or any of that sort of things, because they range so widely, and we also aren't here to diagnose or to tell people what their experiences are. They have physical, emotional, and mental effects on a person. They're very all-encompassing. They can have social repercussions, they can have physical repercussions, and these are all very difficult for a person to go through as a result of an eating disorder. So, common coping mechanisms are used to cope with trauma and highly distressing emotions and thoughts. You can think of trauma as either acute or complex. So an acute form of trauma would be a car crash, for example, or you can think of complex trauma as, for example, systemic oppression and discrimination. And that doesn't mean that these things are always going to cause trauma. It's just that it's a common comorbidity of these sort of incidents. So systemic oppression and discrimination includes people in larger bodies, transgender people, gender diverse and intersex people, individuals with disabilities, or Black, Indigenous people of color. EDs are also heavily influenced by diet or fitness culture, but those aren't the only factors involved. There's also many biological or environmental factors. As well, we really want to stress that eating disorders cannot be determined through weight, BMI, or appearance. You should never use weight, BMI, or appearance as an indicator as to whether or not someone has an eating disorder, because there is just, frankly, too many associations, especially within medical communities, who use weight loss or weight gain or BMI or appearance as a gauge as to how healthy or how sick someone is. So the ways that disability intersects with eating disorders typically goes along two lines, which is distress triggers and physical barriers. So distress triggers provoke distressing thoughts or feelings, like the name would make you believe, based on specific characteristics of a disability, or they occur as a result of treatment for a disability. These are not characteristics that are shared by all individuals with disabilities, since they manifest differently depending on what type of disability a person may have. Person-specific barriers is kind of the way that you can think about it, since they manifest directly due to a person's symptoms or needs or limitations or boundaries. They can include things like the side effects of medication, distress attributed to managing their disability, food allergies or intolerances, the social stigmatization of visible disabilities, or a lowered threshold for pain or fatigue. Coping with these compounding negative experiences really can trigger someone to use eating disorders as a coping mechanism, or it can be used as a means to directly address or circumvent these effects on the individual. For example, if someone feels one of the side effects of their medication is nausea, they may be less willing to eat around the times that they're taking their medication to try and avoid that nausea. The second type of intersection is physical barriers, which is based on physical or social effects that commonly occur due to disability or condition more generally. So these are more commonly experienced no matter the specific type of disability that one person may have. They can be thought of more as societal barriers due to the fact that they originate from a wider lack of accommodations or understanding within society, which makes them commonly shared experiences or frustrations within the disability community. These can include access to food, which means food insecurity, accessible buildings and structures, ability, knowledge, opportunity for cooking, movement limitations, lack of intersectional healthcare, inability to participate in social activities, and limited financial or professional opportunities. These physical barriers leave someone more vulnerable to eating disorders due to traumatizing social structures coupled with a lack of understanding or education about the needs of disabled people. All right, and then we will talk about eating disorders in people with mobility issues. So eating disorders in those with mobility issues occurs across three fronts. It's impacted by facilities, body, and treatment. So facilities refers to the fact that facilities, as in places specifically designed to treat or to address eating disorders, or even just community centers or care support networks, are not designed for mobility issues. And as well, doctors within those facilities are not educated on how to approach the topic of disability. And this can include using labels like unhealthy, incapable, or non-compliant, simply by existing in the body that that person has. It can also include a lack of representation and therapeutic discussion of a person's mobility issues. So avoiding those topics because there's a misunderstanding or a concern about a lack of education with the professional. And these marginalizations, along with many others, can lead to a sense of deficiency and can be responded to by coping through mechanisms like eating disorders. Second is through the body. Mobility issues can also damage a person's physical and emotional connection to the body, increasing the likelihood of a negative body image arising from the feeling of being different or in the way. And then this is further encouraged by social stigmatization and structures that oppress people with disabilities. This also plays into the education of people with disabilities because these feelings are wrongly considered to be eating disorder behaviors or eating disorder feelings when the roots of these concerns are actually entirely separate and require a different form of support. And then the third one is through treatment. There are many aspects of treatment for eating disorders that remain ignorant to the realities that individuals with disabilities face. For example, phrases like joyful movement can be ableist by design. As much as I would love to move joyfully every day at every minute of my life, I also have to acknowledge the fact that I have limitations in how I move and what my movement looks like. And to have someone encourage me to move joyfully at all times really can be down-putting and demeaning to the experiences that I have and the way that I conduct myself in day-to-day life. So just like I would encourage myself and the people around me in general, we really want to emphasize the idea of encouraging what makes sense for each person and their needs. As well, eating disorders have a high correlation with conditions affecting diet. And so when we talk about conditions affecting diet, we're referring to things like type 1 diabetes, more commonly referred to as T1D, irritable bowel syndrome or irritable bowel disorder, IBS or IBD, celiac disease, or cystic fibrosis. So these occur across 3 lines: misdiagnoses, stress, and treatment. So misdiagnoses is a very large concern with conditions affecting diet because of the fact that they affect diet. Manifestations of diet affecting conditions are wrongly attributed to eating disorders. So these can include either intervention methods, symptoms, et cetera, like nutrition monitoring, certain rituals around food, or food restrictions. And a lack of appropriate screening tools really makes people unaware of the ways that conditions affecting diet can mimic what seems to be eating disorder symptoms. As well, eating disorders are a common comorbidity of diet-affected conditions, but they're severely under-researched and neglected. And so there's a lot of question marks about what exactly these look like and what kind of trends we can see because there just hasn't been the research that's necessary. As well, there's a lot of stress that comes with having a condition affecting your diet. This can be through social pressures to conform to expected food behaviors or rituals, or the pressure to look able-bodied and healthy. A good example of this that I like to think of is asking for modifications of a recipe at a restaurant or requesting additional nutritional info. As much as it can be helpful for the individual, they may feel like they're coming under larger scrutiny or they may feel like they're causing a scene by simply asking for something that's entirely understandable and necessary to ask for them. As well, there's a lot of fear around symptom recurrence due to the constant and necessary exposure to symptom triggering materials like food. So for people with chronic pain or chronic conditions, there's always a concern that symptoms or flare-ups are going to happen. But for conditions that are affected by diet, it's an even larger concern because they have to be exposed to food. They can't not do these things, and they have to do it regularly and in a very conscious manner. So this stress can really create large fluctuations of stress multiple times a day as you're facing this really difficult thing that can cause a flare-up. As well, there's a concern around inaccessible treatment facilities, and this includes lack of accommodations, a lack of education or representation, a lack of flexibility, and very strict ideas of what recovery or success looks like. So lack of accommodations can include making sure that there is safe insulin injection sites to make sure that people are injecting their insulin in a way that's hygienic for themselves and will reduce secondary harm or anything like that. Lack of education or representation, as I've already discussed, can cause misdiagnoses or misattribution of symptoms. A lack of flexibility in treatment can mean that the treatment plan is unable to adjust to the needs of the individual and their condition, which causes them to either have to sacrifice their recovery or sacrifice their health based on their condition. And as well, strict ideas of recovery or success can really cause someone to feel like they're failing, even though they're doing what's best for themselves simply because they're not following strict ideas of what recovery looks like. As well, there's a lot of physicality that comes with recovery, and the food, weight, or lifestyle intervention poses a greater health risk when there's an underlying condition that can be affected by diet changes. For example, celiac disease for inpatients is a really big concern because you see it a lot that people with celiac disease require doctors that understand the disease and understand the ways that it manifests and can respond to that and respond to a person's concerns around food because of that. But there's also physical concerns about the ability to have foods that meet certain nutrition requirements and fear around standing out or looking different, calling attention to yourself for having a different meal than other people within the same inpatient facility. So one of the other common coping mechanisms that occurs with disability is substance use. And we kind of want to talk about how that intersects with eating disorders and how that intersects with disability too, to kind of understand the idea of harm reduction, which we're going to be talking about in a second. So substance use is a broad term that covers prescribed medications, over-the-counter or topical medications, illegal or illicit drugs, or natural remedies. And some of these seem more obvious than others, but substance is really a broad term that can include a lot of different things. And we don't want to kind of put the idea of substance into a box that creates more social stigmatization. So yes, the medication that someone may be using to cope with their pain or to manage their mental health can be considered a substance, but so can coffee or CBD or alcohol. And so we really want to acknowledge the way that substance is a broad term that refers to a lot of different things under this umbrella terminology, I guess. We want to avoid stigmatization as well around these topics, but we do want to encourage awareness and education about potential harm to try and minimize them. And that's where the idea of harm reduction comes in, like we'll discuss in a second. And people with disabilities are especially vulnerable to substance misuse. Note I said misuse, not abuse, because there's no such thing as abusing a substance, because substances are necessary for some, and we'll talk about that as well. And substance misuse can include mixing substances, high dosages, illicit substances, or even overdosing. So why does this happen for people with disabilities? Well, there's a large emphasis on pain or symptom management rather than cures, and this is simply due to the nature of chronic conditions. And when I'm saying the nature of chronic conditions, what I am referring to is the physicality of symptom manifestation and the ways in which doctors and professionals are underprepared or lack the research necessary to provide other interventions for someone who's struggling with pain. There's also a lot of discrimination, and physicality of those symptoms can lead to a higher need to cope or reliance on substance just to function in day-to-day life. Chronic conditions are long-lasting and recurring, and they also lack treatment options. So although someone may feel that they don't want to use pain medications, if they lack other resources that they can rely on, this may be the only thing that they are being pointed to by their doctors because of a lack of understanding or research. And it's not just between individual doctors, it's also a systemic problem of a lack of funding, education, and research around these chronic conditions and the ways in which we can treat or address these long-lasting and recurring concerns. And when I say cure, I'm referring to a complete alleviation of a condition's effects and the need for intervention, which again, for chronic conditions that are recurring and long-lasting, is not a reasonable goal based on where we are with education, research, and understanding of these sort of conditions. Treating acute and chronic conditions the same is dangerous and ineffective, and it will not work to help that person with a chronic condition the same way that it would an acute condition. And when I say acute, I mean like breaking a leg. As well, doctors or medical professionals that feel underprepared or undereducated are going to lean on the roots of the medical system and kind of the basic instinct, which is make pain go away now, worry about the rest later. But the problem with that is that a lot of these medical system roots are actually based on very narrow ideas of what treatment and what symptom manifestation will look like based on very limited research into the expected patient, which again is the same as it is with an eating disorder. It's a cis white person of middle age without a disability, and no sort of deviation outside of that. As well, the effects of medication will lessen over time with increased usages, leading to higher doses, and the doses are heightened in order to create the same effect within a person, but that heightened dosage also doesn't acknowledge the fact that your body has already hit the dosage that it can manage. And just because it doesn't have those same reactions doesn't mean that it can process more the same way. So there can be a serious lack of education for patients about side effects or dosages, and those can lead to withdrawals or overdose, or just general feelings of losing control over the body because your symptoms are not manifesting the way that you are trying to make them manifest. And finally, a big one is that there's a social motivation and incentive for substance use, because it can ease symptoms such as pain and fatigue, and it can also ease anxieties, which makes social use a lot more appealing because it removes all these barriers that someone may see between them and social opportunity. So next, we want to talk about substance necessity. So we really want to talk about substance necessity because it's important to remember, like I said before, that substance use is not a bad thing. Medications and substances, whether they're prescribed or not, all have a very real and necessary role in coping with disability or coping with chronic pain or coping with chronic conditions. The reality is that most people are very aware of the health impacts or any dangers or risks that their behaviors might lead to because they're experiencing it, they're doing this thing. And it's important to recognize that someone is doing the best they can given the circumstances. They're fighting, they're trying to process and understand life and trauma by using coping behaviors and creating space for more processing and more survival. We don't want to ever imply that someone doesn't understand the circumstances that they're in or can't grasp the gravity of the situation, because it no longer provides that person with agency, and it also infantilizes and dismisses them. Instead, we really want to open up a space for conversation and take a approach of trauma-informed care and harm reduction rather than dismissing one person, and really focus everything around supporting the individual and meeting them where they're at in respect to their choices and their capabilities in the moment. So as well as all of that, more specific for disabilities, presence of chronic symptoms can prevent complete discontinuation of medication and substance use. It's not always reasonable to ask someone to stop using substances entirely, especially when there are substances that keep people alive. Discouraging substance use or downplaying its necessity is only going to invalidate a person's experiences, and it can cause trauma. It can cause trauma or distress between that person. So instead, we don't want to focus on passing judgment, forcing someone to give up coping mechanisms, or dissuading substance use. We want to focus on harm reduction. So in regards to harm reduction for substance use, there are a couple of little things that we can include when we're talking about that. These are some examples, and obviously we're going to be providing more resources later on about what harm reduction can look like in a bunch of different settings. But in regards to disability and substance use, these are some big ones. They can include testing your drugs to make sure they're safe, drinking a lot of fluids, utilizing safe injection sites, and practicing hygienic practices around drug usage, recognizing the signs and symptoms of withdrawal and overdose, as well as carrying some sort of overdose kit with you, avoiding sharing any sort of substances between individuals or tools, keeping track of your amounts or forms of substances that you're absorbing in some sort of capacity. It can be verbally with another person, it can be written down, it can be on your phone, anything you like. Making sure that you're well informed about medications and substances and their side effects, following directives on packaging as best you can, being honest with your healthcare practitioners about what kind of substances you frequently use or you frequently use to manage your pain, so that they can kind of adjust other medications or other substances to kind of minimize the amount of harm that can be caused. And as well, avoid mixing multiple substances if at all possible. So now that we've talked about substance use, we're going to talk about some of the origins of this systemic oppression and discrimination that comes with having a disability. And that comes with the able-bodied standard. And the able-bodied standard refers to the social expectations of the functionality and aesthetic of a person, specifically based on the body and its productivity. And really, all of this boils down to a pressure to conform. And the pressure to conform comes in a variety of different ways, but specifically in regards to the able-bodied standard, it can pressure people to conform to these unachievable standards of self and body appearance and body functionality. And all of this is kind of a smaller subset of the idea of the beauty standard, which intersects across a lot of different marginalized communities and marginalized identities and can look very different, but we're specifically talking about disability and the way that disability intersects with this idea of beauty. So people with visible disabilities can feel that they're pressured to hide their disability or to make up for it. And this can include sexualization or strengthening or emphasizing other parts of the self to make up for the fact that they have a disability. Or it could be invisible disabilities, which receive more invalidation, and their pressure can look like just pressure to justify, downplay, or hide their symptoms because they don't feel they have grounds to kind of be disabled because they lack physical markers that people can immediately recognize as an attribute of being disabled. And I know for me personally, having an invisible disability and being someone that doesn't have any physical markers, that I struggle with chronic pain and chronic fatigue, it's very difficult to kind of to navigate a world in which I need to either prove or like overcome being a person with these kind of issues. So it's important to keep in mind that even if someone doesn't appear physically disabled or doesn't appear visibly disabled in any sort of capacity, that doesn't mean that they aren't a person with a disability. And that doesn't mean that they don't receive this able-bodied standard pressure. As well, there's really the issue that beauty standards can fracture self-esteem and body image more generally. The diet and fitness culture encourages very unachievable physical appearances or unrealistic expectations of participation in beauty rituals. And this can look like buying expensive workout clothes, doing intense workouts multiple times a week, but it can also look like spending a lot amount of time doing your hair and makeup. It can look like wearing certain clothes and things like that. There's and as well, there's an expectation of body functionality and productivity. And this can really create negative associations and a sense of burden with someone who needs accommodations or accessibility changes. So there's kind of the idea of what a person looks like or how a person should appear, but there's also an expectation of how a person should act. And any de-alienization from those points really causes a lot of social pressure and social stigma that a person has to deal with on a day-to-day basis, and that can be incredibly distressing. So one of the ways that we seek to kind of address this able-bodied standard and move past it is with the idea of body neutrality. And body neutrality, to kind of understand it, we first want to talk about body positivity, which is a little bit of a complicated topic. So I'm going to probably go on a little bit of a tangent for it, but that's kind of important to understand and contextualize body neutrality. So the official definition of body positivity is that it's a movement that approaches the body and self in a positive manner, focusing on acceptance and love despite circumstances. And it seeks to reframe negative conceptualizations of self perpetrated between individuals, so interpersonal relations. However, it is incredibly problematic because even though it's gained traction a lot over the last decade, the roots of this movement and term come from Black and disabled folks, and they champion for acceptance and positivity relating to their over scrutinized and oppressed bodies. However, white cisgender heterosexual women have, in a lot of ways, co opted this movement and changed its original meaning. Body positivity has become this non intersectional and almost exclusive group that only focuses on the achievements, feelings, and thoughts of white women and a handful of quote token Black, Indigenous people of color to give the illusion of diversity without actually acknowledging the immense amount of variety that each person has in their experiences. It's so far removed from its original kind of motivations and roots of the movement that a lot of the times people who seek to participate in body positivity are actually blocked because they operate too far outside of what is expected or allowed for someone to be, even in a movement such as body positivity that really tries in its original form to emphasize all differences and all the ways that people can be and represent themselves and just accept themselves as they are. And a lot of the times that this frankly comes down to the fact, again, of beauty standards and the idea of perpetuating a very specific narrative about what is allowed for people to look like, but also what is allowed for people to feel, to think, to act, any of these sort of things. So because of that, it's really problematic to use body positivity as a sole way of looking at the self or approaching kind of the relationship between the self and others, or kind of the idea of what we think of our body and our capabilities. As well, a lot of the times people use body positivity and focus on function rather than appearance because they want to try and move away from the idea of emphasizing appearance. But having a disability can really interfere with your ability to have these functions that people will emphasize when they're talking about body positivity, and that can be really problematic. So for example, someone might say that they love their body because it lets them dance to all of their favorite songs every day of the week that they want, and they enjoy that movement and it makes them happy. And that's great. And we want to celebrate that ability for them and the wonderful feelings that it provides for them. But there are also days for myself where the idea of dancing is exhausting and painful. And so on those days, I don't want to love my body for those reasons because I don't have those reasons to love my body. So we want to kind of reimagine this idea of approaching the body in a way that kind of takes into account all these difficult emotions and this emotional variability that someone might have in relation to their body. It's also problematic to suggest that someone's concerns or complaints about their body can be solved just by ignoring them or reframing them as positive qualities. And if anything, that just further removes a person's autonomy and ability to kind of articulate what they're going through, and it forces them to fake their positivity or force their positivity when it's not actually an appropriate way of them processing what they're going through. In Another way of approaching it in a very different fashion than body positivity is body neutrality. And body neutrality focuses on approaching the body more neutrally without these preconceived notions about what's an appropriate attitude to take towards a self. So this can include forced positivity or fake positivity, but it can also include self-hatred. Body positivity allows someone to acknowledge their limitations and the complex emotions that can arise around the body and the self. It also enables a lot of honesty about the effects of disability, trauma, and social pressures on the self. So, for example, someone who approaches themselves with a body neutral point of view might say, yeah, sometimes it sucks. I don't like being in pain. I don't like having a disability. I don't like being someone that faces social stigmatization. And that's okay. And that's where I'm at. And then that's the end of the conversation. And that kind of space allows them to process these really hard and complex feelings in a way that doesn't feel like there's a pressure to get it over with and skip to the fun, happy stuff already. It lets them really feel these emotions that they need to feel to be able to get past and process their traumas. And it doesn't mean that one necessarily has to be practiced and the other one has to be forever ignored. The same person can practice both body positivity and body neutrality at different points in their life or different times, even based on their needs and what their current perspective is. For example, I know for myself, I use both interchangeably depending on where I'm at emotionally, physically, what is happening in my environment, and things like that. It's all about meeting the individual's needs and allowing them the space to feel whatever it is they might feel in regards to themselves, in regards to their body, in regards to any aspect of disability or body or functionality or anything like that. So, kind of tying in with body neutrality, an important part of the able-bodied standard, and another way that we kind of see disability intersecting with these institutional or systemic oppressions is with fat phobia. So just really quickly, we're going to define a couple of important terms around fat phobia. Fat phobia refers to the systemic oppression, the system of oppression, that systemically marginalizes fat bodies, manifesting attitudes of stigmatization or discrimination within these people. And this can look like intrapersonal, so your self-image, interpersonal, so your perception between people, or institutional. So way I like to think about it is intrapersonal is the negative self-talk you say when looking in the mirror. Interpersonal would be the bullying that someone might be experiencing in school. And institutional might be a lack of accessible clothing sizes or a lack of representation within media. As well, we have body mass index, referred to as BMI, which refers to the ratio between someone's height and weight. And it is one of several tools that many people use to gauge eating disorders or to gauge health concerns, but it really is a false association of health and size, using a very inaccurate and flawed measurement that has never been able to really understand or conceptualize someone's weight within their personal or social factors, including the ways that disability can interfere with someone's ability to lose or gain weight. And that's not to say that someone has to do any of these things, but it's important to consider the ways that these secondary factors inhibit this, this marker in a way that a lot of people aren't willing to consider when they look at measurements such as BMI. And fat phobia also really can manifest in a bunch of different ways, specifically with diet culture and fitness culture. So within these systems, there's this push for the ideal body. And I say that with quotes because it's not an ideal body. There's no such thing. But this ideal body that diet culture and fitness culture pushes demands a lot of time and money and energy. There's a large expectation about the time and energy that should be spent each day on conforming to beauty standards. And this can include, like I said before, expensive supplements, special workout clothes, complex makeup routines, or exercise programs. As well, this push for an ideal body and this usage of these tactics to achieve it is actually draining and taking time away from actions that are motivated by real wellness of the individual. For example, someone may feel that the best thing to do for their body and their wellness is taking a bath. But instead of doing that, they may feel pressure to go and work out or to go and, get a facial or something without actually acknowledging the ways that what they're already doing is what's best for their body and what's best for their state of mind and their overall wellness. As well, there's a lot of weight stigma within medical care, and this weight stigma reinforces the connection between health and size because it uses weight as an indicator of wellness. This can include the use of inappropriate diagnostic tools like BMI to diagnose eating disorders rather than taking into account the consideration of various social, personal, and biological factors that might contribute to someone's eating disorder. It can also include denial or inadequate care for people in larger bodies as they're subject to dismissal, invalidation, or increased scrutiny around their symptoms. As well, fat phobia in the medical system can cause medical trauma, which we will talk about more later. And we really want to emphasize that no matter what, weight loss should not be prescribed as a treatment for chronic conditions. and weight or appearance should not be used as a tool for determining the severity of someone's health conditions. And this can be in eating disorder treatment or in diagnosing eating disorders, but it also is just a really good practice to take more generally, that weight loss is not a treatment option in itself. It should what really should be given to the person is a more complete and complex understanding of what they're going through and what can best address the symptoms or concerns or the underlying problem that they're trying to address. So, like I said, we're going to talk about medical trauma, which is another important topic to consider, especially when we're talking about systemic oppression and fat phobia. It's a good little segue to kind of discuss medical trauma and what exactly that is. So medical trauma refers to any sort of discomfort, aggression, anxiety, or hesitation around medical topics, including the fear of medical supplies or tools, avoiding appointments, lying to professionals, rejecting diagnoses, ignoring treatment plans, or more. And then there's another important term is medical gaslighting, which refers to the repeated denial of someone's reality, in particular, the usually arbitrary dismissal of someone's concepts, concerns or symptoms as minor infractions or manifestations of a psychological concern rather than an actual health condition. So this can look like refusing to provide referrals, refusing to provide pain medication, avoiding or dissuading any use of terminology like disability, condition, illness, problem, etc. when the person uses it, or questioning someone's mental wellness when they bring up health concerns or health conditions. So this kind of thing can be really damaging to a person because it not only denies them the care that they need and traumatizes the individual, but they can also take this feeling of not knowing the self and doubting their own personal experiences into their later medical interventions or their seeking of support. And this can really impact the ways that they advocate for themselves or they push to acquire the care that they need. So medical trauma and EDs intersect a lot, especially with people that have chronic conditions or disabilities, because they typically have more exposure to the medical system, which leaves them with more vulnerability to obtaining medical trauma, especially when you couple this with other forms of marginalization or oppression that the person may be experiencing. There's the treatment of a patient is seen through a lens with multiple biases, and this can skew the doctor's perception of what adequate care looks like, especially when they're unable or unwilling to kind of dissect their own thinking patterns and the reasons that they believe certain things about certain patients. As well, small occurrences of fat phobia, ableism, racism, homophobia, and transphobia make healthcare an unsafe place. And even if someone feels that these small occurrences are something that doesn't traumatize them, a gradual accumulation can also compound into trauma over time. This is not even to say that self-advocating in itself demands a lot of emotional labor. And when this is coupled with symptom management, it can really become overwhelming or impossible to do both at the same time, especially when you consider the fact that someone may be juggling very specific approaches or attitudes that they have to face on a day-to-day basis in regards to either their diagnosis, their treatment, or just their disability more generally. Eating disorders are a coping mechanism for trauma that reinforce control over the body. They let someone cope with the distressing thoughts or feelings that arise based on their experiences, and this translates into their experiences with medical care. There's a misconstrued conception of health that's created by fat phobia and weight stigma within medical health care. And this can lead individuals to try and address health issues primarily through attempted weight loss. So rather than going to a doctor for a concern that they may have, they may instead internalize whatever it is that doctors have previously told them about their experiences and then extrapolate that onto any further medical concerns or personal problems that they see. And then this kind of cycle is then further reinforced by the idea that's pushed forward by diet culture and fitness culture, which is that if you achieve the standards or the ideal that we're pushing you to get to, everything else will be fixed. And this isn't realistic and it's not achievable, but kind of having this messaging reinforced in so many different ways can really push people to harm themselves in a bid to get better. So how do we address all of these intersections and these problems that we see in regards to medical care, in regards to fat phobia, in regards to substance use, and the intersection of eating disorder treatments and for people with disability? One of the best ways to do that is holistic care. And holistic care refers to providing support that considers physical, emotional, social, and spiritual well-being. And this pretty much means we want to look at the entire person rather than any specific symptoms or concerns, taking into account their history, their background, their experiences, their identity, and the ways that all of this can compound together into one person who has a unique experience and has a unique perspective on what it is they're going through. It also seeks to make up for a lot of the inadequacies that we see within medical care by establishing a new form of support or new opportunities for treatment. Many institutions of care are based around really strict ideas of symptom manifestation and treatment, which leaves them ill-equipped to address the concerns of marginalized groups and really increases the likelihood of misunderstandings or miseducation on topics. So another really big example of that is inaccessibility of care, with lack of accommodations, inaccessible facilities, lack of representation, and a lack of education among staff about how to approach the topic of disability. As well, a lack of education around disability, like I've said before, can cause professionals to attribute markers of a disability to an eating disorder. And it doesn't just have to be with diet-affected condition. You can also see it with someone with difficulty with understanding or conceptualizing the self. You can see that it may be caused or motivated by some sort of struggle that comes with having a disability, but without the proper education or understanding of complex issues surrounding disability, a doctor may just falsely attribute that to an eating disorder or negative self-image or anxiety or things like that, without understanding the really complexity that comes into these issues before we even reach this point. So this is where we stop for a second, take a little bit of a break, and we open the second question, which is, how much do you know about community resources in your area? And this can refer to specific types of resources. This can refer to hotlines, support groups, anything like that. So if you want to just kind of rate what you think between 1 to 10, 1 being I don't know anything, and 10 being I'm an expert, where do you think you fall in regards to your local community resources and how much you know about them? Okay, I'm going to give you guys a second to kind of think about it and also respond if you feel up for it. And then we're also going to check back in a second on this.
Can y'all send the link for Slido for the people who came in late? I think it was me and a couple other people. Thank you.
Okay, so while we're waiting for those answers to finish up, we'll just jump right back in, talk about a little bit more stuff, and then talk about the answers to the questions and why these sort of community resources are so important. So what is most important about these kind of things is creating a support or treatment plan. Taylor, I think you are, oh yeah, you're good, just kidding, sorry, I thought you were frozen. My gosh, creating a treatment or support plan. So really the goal of a treatment or support plan is to ease anxiety, provide direction for support and accountability for both parties involved. And this can look like with a healthcare practitioner making a treatment plan between you and your doctor, but it can also look like sitting down with a friend and outlining what kind of support they need from you or they feel would be most appropriate in their circumstances. Connecting directly with that person to determine the level of support or care they need can work in finding different avenues or networks that they have access to. And it can be used informally as well for community organizations, personal counselors, family members, or institutions that are entirely separate from care. So it's typically divided into 2 groups, community support and professional support. Community support is considered a more flexible and accessible form of support, especially for individuals with medical trauma or those who lack access to appropriate medical facilities. Community support can be rapid response, like helplines, short-term or long-term. They also include support groups, shelters, accessibility volunteers, advocates, peer coaching, etc. Really, one of the benefits of community support is its ability to address more nuanced experiences and provide an increased amount of representation and education while also increasing financial and physical accessibility. So you're less likely to see paywall issues or concerns about the form of treatment that you can receive within a certain time frame for community support compared to professional support. So professional support refers to specialists and medical professionals who have access to traditional forms of treatment, including medication and intervention tools. And these are also a very important tool for seeking support if someone feels that it's appropriate for them. They have the ability to provide referrals within the medical system and also provide diagnoses that can be recognized within most major institutions. They are, however, very limited in the form or length of care that they are capable of providing, and they're more likely to experience financial, social, or physical barriers. And this can look like cost, but it can also look like long wait times, lack of professionals within your area, or any number of other things that can impact someone's ability to seek care in that way. So now we're going to check back in to the poll answers and see how much you guys know about local community resources. Okay, so a good mix. I like to see that. I'm glad that we're over 5 on the score. That makes me happy. However, the low scores really indicate that there seems to be a really big disconnect between community support and the associations that come with care. And I think a really big reason for that is simply that there is a divide between professional support systems and community support systems. And a lot of the times we don't see healthcare practitioners who feel comfortable providing community references or feel providing someone with resources to a community group or things like that. And that's kind of where we and other organizations like us come in to kind of expand people's repertoire of resources and referrals that they can use to try and access care that feels like it fits with what they need best. So we're also going to talk about it at the end a little bit. I'm going to have Cody talk about it a little bit, and we're going to provide some resources in the chat. And also, yes, thank you, Cody. Anyone who wants to share resources, you're always welcome to and open to, but we really want to try and build and provide people with as many different avenues of support as they can possibly have, and encourage more as time goes on and you learn more and you receive more opportunities. All right. So next, we're going to talk really quickly about trauma-informed care because it's important to know for medical professionals, but it's also just important to know for day-to-day use and for personal relationships, because a lot of the things that are staples of trauma-informed care are really important or necessary for us to take into our day-to-day interactions and our understanding of others and approaching the care or support of others. And that's because the focus of trauma-informed care is around autonomy and control. And I have mentioned this before a couple of times, but I really want to stress how important it is to respect a person's autonomy and provide them with control and agency over their own life and their decision-making. Specifically, trauma-informed care acknowledges that healthcare organizations and care teams need to have a complete picture of a person's life, past and present, in order to provide effective healthcare services with a healing orientation. And like I said, these are themes that can be carried into personal relationships and support situations. We want to provide the person with as much autonomy and control as possible. We want to respect their choices, their needs, and their boundaries. It emphasizes and focuses on validating, understanding, supporting, and connecting with a person, but never trying to force them to change or dehumanizing them and their abilities. We also want to avoid perpetuating this sense of loss of control that comes with trauma and marginalization. It's also important to acknowledge with trauma-informed care and harm reduction, as we've said before, that coping is necessary and vital to a lot of people. And we don't want to see this as something that's bad or requires stigmatization or intervention beyond what a person is comfortable with us intervening. As well, we want to really reframe the idea of recovery as an abstinence, not as a success, because we don't want to see recovery as a success and relapse as a failure, because that kind of puts recovery on a linear progression. But the fact is that recovery is nonlinear. Relapse is a necessary and sometimes is a common and sometimes necessary step to achieving a more well-rounded and safe version of self-conduct and of ways of kind of seeing yourself and the people around you. It's not to say that someone who relapses is failing in a circumstance, but rather they're taking a journey and they're processing and learning and grieving and coping with the information that they're learning. And along with all these things, we really focus around 3 stages in regards to trauma-informed care. The first being establishing an accessible, safe space to talk about experiences, thoughts, or feelings around eating disorders. And this can look like appropriate use of language, active listening, accessible facilities, and confidentiality. And it can also look like just making sure that you're there for a person to the best of your abilities or to the most that you can provide in the ways that they feel are the most appropriate for them. Second is giving time and space to acknowledge and mourn the losses that come with trauma and having an eating disorder, because there is a lot of trauma and loss that comes with having an eating disorder, whether it's personal, social, physical, or other. And this can look like experience-led discussions, providing resources or practices, minimizing distress, and other things like that. Finally, then after these 2 steps, we can focus on reconnection, where healing lets someone rediscover and reconnect with their body, including their relationship with food and the self. And this can look like practices such as intuitive eating, mindfulness, trying out new experiences, social participation, and more. So like I said, this is really kind of a form of care that is typically associated with medical professionals in a medical setting, but it has really important themes around agency and control and respect that we can carry into any sort of support circumstance or any sort of practice that we do as an individual, either professionally, personally, or socially. And so when we're talking about eating disorders specifically, once we've kind of established the basis of eating disorder, trauma-informed care and harm reduction for other substances, we want to try and make eating disorder support in general accessible. And there's a lot of different ways that we can do that. We need to take into consideration all the ways that disability can affect a person's recovery path or ability to access care. We also have to acknowledge the harm that marginalization perpetuates, including the traumatic impact of ableism, fat phobia, cis heteronormativity, racism, and sexism, among other forms of marginalization. It also enables us to encourage a critical understanding of the medical system, and we want to embrace holding major social structures accountable for the harm that they perpetuate by playing into these marginalizing structures. So this is a big list of a variety of ideas and typically approaches that people take when they are asking for accessibility increasing. And it can be divided into personal actions or professional actions. And obviously, not everyone is going to be a doctor or someone within a support situation who's able to provide professional care or to provide these professional changes. But it can also look like asking more from the people around you, asking more and remaining critical and understanding and continuing to educate professionals that you come in contact with in a variety of ways. So personally, this can look like using appropriate language, like we discussed before, asking and mirroring. It also can look like treating people with respect, allowing them to act with autonomy, practicing self-awareness within your bubble, and accountability for yourself, your friends, and your family. Being receptive to what other people choose to discuss. And this can look like someone being receptive when someone chooses to disclose to you something about their experiences, but it can also look like someone choosing not to disclose or verbalizing that they're setting a boundary and you respecting that boundary as it is and not trying to push them or to learn more for your own benefit rather than for theirs. As well, we want to make sure you're not making assumptions about the limitations or needs of others and are really waiting for them to conduct your own involvement in whatever it is that they need you involved in. We also want to support and encourage individuals finding and accessing accommodations. And this can look like choosing venues based on their accessibility or encouraging someone to use accommodations that they want to use but feel either anxious or stressed about obtaining. As well, we want to avoid patronizing or romanticizing someone else's experiences, especially when we're acknowledging the fact that we can't know for sure what that person is going through and how that's affecting them. And finally, we can encourage continuing to research and educate yourself about topics surrounding disability. So this can mean learning more from specific people, but it can also just mean learning more and more generally, using community resources or studying these topics in more depth. So professionally, like I said, I'm not expecting everyone to become a doctor overnight and start a whole new revolutionary practice for medical care and for accessible treatment. But there are a lot of things that we can call attention to within the system that we have and ask for more and ask for better from the people that we are seeking support from. And it's a lot of it follows the same kind of lines. Using appropriate language, continuing education and accountability around fat phobia, ableism, and other forms of oppression, allowing space for autonomy, respecting individual boundaries and limitations, encouraging accessible facilities and practices, including manners that we disseminate information and providing online options when at all possible. But it can also look like using screening tools and treatments that have been validated as accurate or helpful for marginalized groups, rather than relying on outdated diagnostic criteria like we see with BMI, or dedicating resources towards expanding accommodations or education around disability, including budgeting for accessibility tools or consultations and a constant education from a variety of sources. So now that we've talked about all that, we can kind of hop back into the idea of resources a little bit more. And I'm actually going to hand it off to Cody so that he can talk a little bit more about resources, but also just talk more generally about what Safely Connected does and all that. So I will hand it off to you, Cody.
Hi, sorry everyone, I'm just pulling up my notes, but hi, I'm Cody. I go by he, him pronouns, and I'm forgetting my role. I'm the executive director of Safely Connected and the founder, which I also really want to thank Simone for. The workshop isn't over. We're going to have a whole Q&A, but before I start, I also want to give a big shout out to Simone for doing her first workshop on behalf of Safely Connected. And she's been doing a truly incredible job researching and creating content on behalf of the center in relation to this topic. And really just it's an 8-week position. We have 110-page manual, and it's been very impressive and just an honor to work with someone who just took our content and brought it to expanding it in this way. So it's been a wonderful workshop, and I want to point that out before I start saying anything. So I'll read out these resources and give a longer description of Safely Connected after that. I also want to point out that these are pretty limited resources. We're a brand new not-for-profit. We incorporated in November 2021. We've done a lot of development, a lot of work, and we have a very strong basis of having 4 years of planning before that. But we're really extensively developing all of our resources. The aim is to have not only eating disorder resources, but general resources for anyone who needs them, who is from a marginalized community, because we know that it is incredibly hard to research any kind of resource. And so as a community-based group that is kind of addressing the institutionalized issues in a lot of areas of professional care, we also really want to be a central help in finding resources or navigating them or linking to other websites who do them, who provide them. But to give kind of an example of different peer support spaces, the Tender Fruit Collective. So I'm going to read descriptions from their websites. They offer a peer-to-peer support space that is virtual. multiple times a week to allow for more spaces for neurodivergent, mad, sick, and disabled survivors to heal collectively without state, federal, medical, psychiatric, or police intervention. So as far as I know, they work on Discord, and it looks like a really wonderful group there. I sent the website to Taylor, so I think they're going to put it in the chat. If not, I'll try and search for it afterwards, but they have a website where they kind of describe all these resources, and they have 2 different kinds of Discord spaces. There's Black AUDHD. So in order to be eligible for that support, you need to answer yes to all 3 of these questions, and then you're eligible for no cost one-on-one support. So the first question is, are you Black, Indigenous, or otherwise a part of a global majority? 2, are you queer, trans, or non-binary? And 3, are you expansive, divergent, or disabled? I don't know what Taylor's saying. Okay, well, the links will be sent again. I think that's from our Slack channel. As you can tell, we are a small not-for-profit and doing our best. But yeah, those are basically the 3 questions that they have on their website. Right now, they're not accepting clients, but I didn't want to like point out that resource both because they have an Instagram, but also their website has a lot more on it. And then also Project Let's is a wonderful organization that I've attended a couple of workshops from. So this is the description of their peer support service. We believe peer support is an abolitionist offering where people with lived experience with disability, mental illness, madness, and or neurodivergence support each other and offer a form of accessible, competent, non-carceral, mutual mental health care. We are here to hold people, be present with them, and hear them. We do not judge, gauge, coerce, force, or challenge people's autonomy, and self-determination as human beings. Many power dynamics that exist in a traditional therapeutic model and mental health system are reduced. So I know I'm reading these descriptions quite quickly. You can find all these descriptions directly on their websites. The one thing in common from those three resources that they're non-carceral, which is a strong benefit and very important part of community-based resources, which some professional resources are starting to align with, but for members of marginalized communities, especially, like for everyone, it can be a very traumatic experience to have your agency and control be completely taken away from you, but also especially because of the traumatic nature of healthcare and hospitalization, that can be a very, very important part of accessing community-based resources. And as a trans person who's never had a single positive experience with medical healthcare, I also want to validate how important that is. Then in terms of information advocacy, so I pointed out the Fireweed Collective because they have an internalized ableism survey. So anyone can go through it and you can kind of answer questions and understand how you've internalized ableism in your own life. And how kind of the structures of care have so much of an impact that we all incorporate them in different ways. And that's kind of first step in terms of acknowledging them. And they also regularly have events and workshops from disability justice advocates. And then from Instagram, so these are 3 different accounts that talk about disability justice, disability education, and similar topics to what we talked about. None of these resources specifically cater to eating disorders, and that's something that I also want to point out as a lacking resource and something that in the long term we are planning on dedicating resources and space for. All of the peer support spaces I've seen work in different ways to address different issues around eating disorders, mental illness, and mental health. And so there are definitely one-off events and parts of that community that is there, but it's also quite difficult to find non-carceral, specifically dedicated to marginalized community spaces that are for eating disorders, and that's part of the work that we do on behalf of Safely Connected. So as a follow-up to that, what does Safely Connected do? I'll do a very kind of quick recap, but we have 2 main programs. One of them is training, so Simone is doing a part of that right now. Throughout the year, we are facilitating trainings in organizations. We try and do a couple of kind of public trainings, but because of our limited capacity right now, we've been doing it kind of on one-off requests from organizations. We have an entire workshop on how to provide trauma-informed care. We have workshops on the intersections of disabilities and eating disorders that are a bit longer than this. We have workshops on the intersections of LGBTQ plus experiences with a specific focus on trans and intersex experiences and how that intersects with eating disorders. And much longer. You can find all those details on our website. And if ever you are working on behalf of an organization that could afford to request those trainings, we would be more than happy to provide them. But essentially, all of these are to kind of fall in line with our mandate and create more safe, accessible spaces for folks to access care. And we also reframe and deconstruct eating disorder concepts through the lens of the underrepresented voices in eating disorder care. So our manual has been worked on for the last 5 years and kind of is based on receiving medical and academic information and then completely deconstructing it with the help of different consultation, community-based groups, and like paid professionals that went through our manual and kind of showed the ways in which each concepts like body image, relapse, and I'm not going to go through the entire list of it, but essentially how those can be reframed to be inclusive of all experiences rather than centered on white, cis, non-disabled folks. And then the other part of our services is we run chapters. We have a chapter at McGill. We're starting to start a chapter at UCAM, and we have a bunch of different folks that are interested. Once we have more proper sustainable funding, we're going to be offering a full set of resources, mentorship, and just like anything that students could use in terms of creating their own community-based resources for peers to connect with peers, but also be trained in how to make that space safe, accessible, and as inclusive as possible. And yeah, I'm happy to answer any other questions. And I know that was a lot of information, but that's kind of the gist of what we do.
Thank you, Cody. I appreciate it. You did a great job. Okay, so now I'm going to say thank you so much, everyone, for listening. I really hope you enjoyed this workshop. If anyone has any questions or comments or anything at all that you would like to discuss with myself, with Cody, or just as a collective, please feel free to send a message in the chat to me, to Taylor, to everyone if you feel comfortable with that, or you can use the Slido to submit anonymous questions for us to discuss. And Taylor will provide a link for that in the chat. So if anyone has anything, please feel free to let us know.
And feel free to unmute if you want to, or if you're more comfortable or it's more accessible to you to unmute.
Yes. I'm actually going to stop the recording too. That reminds me.